Well, thank you for all coming, and thanks to Alta Mira for having me here today. I think these talks are great, and it's been a pleasure to work with Alta Mira recently on a few cases, and hope to continue that. So today I'm going to be a little bit all over the place, kind of string together some of my theories and how that kind of reflects with imaging and how one can use various types of imaging in psychiatry and some of the implications for treatment. And I'm going to focus on dual diagnosis, although a lot of this is really applicable across the board for the various patients that I see. One of the aspects of the talk is that I came up with an idea that Freud came up with 100 years ago or something, that impairments in development are important in psychiatry. And more and more I've realized, or I conceptualize a lot of our ailments as developmental abnormalities, and people getting stuck in a more biological sense than Freud was talking about, and how that informs a lot of the psychiatric treatment that I'm doing. And it's really true that development does have physiological impact. I don't know if everybody can see, but it says a body goes through changes during the teen years. When you started dating, my hair turned gray. When you started driving, I got heart palpitations. So we know for sure there's physiological changes in the teen years, and before, of course. So I'm kind of focusing here, in a sense, on adolescence, but really what I'm talking about are changes that really start when you're born, and actually before you're born. And I should probably stand on this side so you guys could see the slides. But what happens in adolescence from 10 to 18, and really even past age 18, is that there's a lot of gray matter loss. And primarily this is happening in the association cortices of the brain. So those are kind of like the transit terminals of the brain that are connecting various parts, various sort of networks that have connections to all over the place, and that's where you're getting a lot of the gray matter loss. But I think a lot of people are thinking about neuronal death, and I think maybe that's true as we get past the teen years. It certainly seems like some neurons are dying. But in the teen years, we're not really talking about neuronal death. What we're talking about are elimination or culling of overproduced synapses. So what's happening is really more of a reorganization than a loss of brain matter. And a lot of this happens in a way where we see that white matter volume is increased in frontal lobes and also in hippocampal relays in particular. I think the hippocampal relays have a lot of reflection in how I think trauma is different in children, and then how it changes later on in life if you have a traumatic event as an adult, and how the hippocampus plays a part in that. And certainly the frontal lobe changes have something to do with executive function and impulsivity, things that decrease as you become an adult. Here's a bit of a blurry slide showing, histologically how neurons grow and then are reorganized. So this is an infant here. So you see a lack of neurons. By age 7, you see just a whole swarm of neurons. The whole place is just taken up with neurons. And then at age 15, you'll see that we haven't really lost neurons per se, but we've lost the synapses, some of the synapses between neurons, and we're reorganizing. And I think all this has some interesting implications. And again, although it occurred to me, and was thinking of this as my theory, obviously there's something that many people have thought of over the years. So I think schizophrenia may in fact be a disorder of neuronal reorganization. I mean, it occurs in late adolescence. Kids are for the most part looking fairly normal. There may be some prodromal symptoms, but they hit 17, maybe even earlier to 20, 21 years old, and that's when the real onset of the schizophrenia takes place. And I think one can also conceptualize a variety of psychiatric disorders as developmental disorders. The one that I'm focusing on more in essence in the talk, because it also has probably more relations to substance abuse, is attention deficit. So many of you have small kids or have had small kids, and small kids are just, walking inattention. They, no matter how many times you tell them to do something, they get distracted and they're off to the next thing, and so you're ready to pull out your hair. So that's normal. It's normal in kids. Obviously, there's going to be some variation in kids of how much they're going to do this. But the problem is that some kids don't seem to grow out of that. And even adults or young adults, we know more and more, haven't really grown out of it, although some of the patterns do change over the years. Similarly, I often think about obsessive-compulsive disorder. Children are naturally fairly OCD. They, won't step on a crack in the sidewalk. They won't have the pea touch the mashed potatoes. They have little rituals. They have all these things that they do. And my wife is always saying, "Is my son obsessive-compulsive?" And I think, no, I think he's pretty much normal. And maybe I'll be proven wrong at some point. Maybe he will continue to have that characteristic, but at least at this age, it's fairly normal. And but in my nephew, who I think is a little, at this point, abnormal, some of those OCD symptoms have continued to the point, till age 13 at this point. So why I'm mentioning it is, I think this has some implications for neuroimaging. And, there's a variety of different forms of neuroimaging. Just an X-ray of the skull, although that's not very informative. We have MRIs, SPECT scans, PET scans. Both of those are modalities where you inject radioactive dye, and they're attached to chemical ligands, and they're taken up in certain parts of the brain that kind of light up. And there's some, uses certainly more basically in research for that SPECT and PET scan in psychiatry. But there's also some deficits in terms of the time frame you're looking at and really what's normal and et cetera. Functional MRI, I think, is probably the most promising new technology, where you're really looking at blood flow to certain parts of the brain, and that's related to the metabolic activity of parts of the brain, and you can localize details, very well. So it's not, although I'll talk about one way of maybe using fMRI in treatment, it's not that clinically useful, but it's an amazing research tool to localize areas of function in the brain. But it, machines cost about $5 million, and, you have to pay about $40,000 a month in upkeep, and it's not generally a useful clinical tool at this point. So what I've focused on, and I've been involved in EEG-based research for like 15 years, is the EEG, electroencephalogram. Some of you know more about it. Pi probably learned that neurologists look at it to look at seizure foci in patients in medical school for 3 days, and that's what I did, and I didn't think there was any other use besides that. But what neurologists are using is really a analog signal of an EEG. So they're really looking at the waveform and looking at the shape of that form, and looking for aberrant activity in that waveform. But since the days of computers, we've been able to attach the computer to the EEG machine, and you basically can analyze the signal mathematically. And so that's called a quantitative EEG. And that is a great interest to me, because increasingly we're able to find out patterns in the brain, and even now with some new technology that I'll go over, really localize abnormalities in the brain in a way very akin to functional MRI. And in fact, many studies are very concordant between functional MRI and quantitative EEG. So over here, I'm just showing you a little bit about the EEG. We have various waveforms, and basically they're frequency bands. And they mean different things in a gross way. So beta activity means excited. Alpha activity means sort of a relaxed but awake state. Tibetan monks have an awful lot of alpha wave activity, for instance. Theta waves are related to drowsiness, or one can even also think of them as inattention. We have certain types of specific sleep waveforms, and then we have also delta waveforms, which happen in deep sleep, but also happen when there's head injury or coma or metabolic encephalopathies. So those forms are all of interest, and sometimes just seeing an overabundance of delta waves just tells you there's something, you know, physically really wrong with this person. But we also have, you know, sort of ways of looking at that numerical data, and one can actually look at the numbers, but luckily we can also translate the numbers into essentially images. And that's a lot easier to look at, for one thing, so I like that. But it's also very telling, and this is a patient I'm going to go over and give you an example of, but what we're seeing are a variety of measures here that are looking at how well different parts of the brain connect and speak with each other and communicate with each other. I won't go into that in great detail right now, but we're also looking at basically the voltage and the percentage of voltage coming from different waveforms in the brain. And what we're looking at here is a mean. 0 is the mean, and it's represented as white, and we're looking at 3 standard deviations above normal or 3 standard deviations below normal, and the red is above normal. So we can see, for instance, here we have a lot of activity, really medial, slightly to the left in this case, and really residing more in the theta range than anything else. So what's also interesting to connect that with the ideas of development that I was mentioning before, the EEG and then the changes in EEG really reflect definitive developmental stages. And so that's of particular interest here. So one of the things is that theta power decreases normally. So if you take a young child, if you can get them to sit still for the EEG, which is not that easy, but if you do, you're going to see an overabundance of theta activity. And as a teen gets older, and as you look at adults, you're going to see a natural decrease in that theta wave activity. As a result, also alpha power activity does increase proportionally, and it starts from the back of the head and kind of moves forward to the point where that moving forward is also associated with ages where some of the impulsivity and poor judgment of the teen years is also, you know, improving, if you would, as you become an adult. So there's a number of things that one looks at clinically, say somebody has ADHD or is stimulant responsive or whatever, but in a gross way, one of the things that's important, one of the major biomarkers for stimulant responsiveness has to do with theta excess. And as I mentioned, theta is essentially an inattention wave. So in essence, this is the EEG of a 6 to 10-year-old probably. But this was actually a 20-year-old. And so what we saw here is poor development of alpha waves, but we have an excess of theta waves, particularly prominent when you look at the relative power of theta compared to the other bands. And that was of import, as I'll go into in a second in discussing his case. If we look at, I'm simplifying here, but we look at excess theta power, but we also look at a few other measures along with it. The sensitivity of discriminating ADHD although I would really put it more as discriminating for stimulant responsiveness rather than diagnosing somebody with ADHD. And normals is about 90 to 97%, which is pretty good. And also the specificity is a little lower, 84 to 94%, but again, pretty good. So compared to what happens in clinical practice, you know, somebody goes to the pediatrician, doctor, my kid just won't sit still, and the teacher says, you know, he's a pain in the neck at school. Okay, well, they must have ADHD, let's give that kid a stimulant. This is actually, I believe, much more accurate than that type of, you know, brief clinical diagnosis that one so often gets. So I actually do use this. A lot of kids or parents come with their kids because they don't necessarily want the kid on stimulants if they don't need it, so we do this testing. A lot of times we have people with addiction histories. We're not too keen about giving them a stimulant unless they really need it, and I think many do really need it. But, you know, this is one way of fairly accurately deciding that issue. So I'm going to get out of this for a second, and I'm going to go over that case that I was showing you there. So this 19 or 20-year-old guy was referred to me from Serenity Knolls, where he, and has a history since, whatever, 16 of cocaine and opiate use, primarily opiates, but he would dabble in both. I mean, he was just, you know, the minute your back was turned, he was back in the tenderloin and picking up. And he was really erratic. They kept on saying to me, this kid is bipolar. You know, he just goes a mile a minute, and he's just really unrealistic, etc. So I gave him some things to calm him down. His anxiety was pretty palpable, and you know, and he did have a, while we were starting to do this, he did have a sketchy history. You know, somebody brought in some drugs. They were able to find out. You know, he was in and out. But then we did the EEG, and then we saw what I showed you already, a number of findings. But one that I was talking about is the excess of theta waves in a sort of a medial temporal area. And here we can see it. I can also localize this a little bit more in terms of frequency slices. These are 1 hertz slices of the brain, and we see that it starts really in the high delta range and goes through most of the theta range. You know, and that's pronounced in the relative power. And I won't go into like eyes closed and eyes open in some ways which we can also further differentiate. But what's also, which one is which? I'm sorry. Yeah, so this is some of the really interesting technology that I've been using. And this is called Loretta. Let me just make that larger. So Loretta stands for low resonance tomographic assisted EEG, basically. So what this is taking advantage of physics, really. So if you have a gel-filled sphere and you have surface current on that sphere, you can calculate the origins of that current and the magnitude of that current. So it allows, and the brain basically acts as a gel-filled sphere. So one can take the surface findings from an EEG and really calculate the current and where it's coming from. And what's done here is that it's superimposed on an idealized MRI image, which is, you know, there were 300 supposedly normal people, and then their MRIs were kind of melded together into an ideal. So one can do lots of cool things, like I can put my cursor over here, and although it's not working for some reason, what's going on? Well, oh, there it goes. Okay. There's something's not working out, but basically I can I can localize areas of the brain and tell you where things are coming from. And sometimes I've had patients, for instance, who have had a remote history of seizure as a child. Turned out that she had some white matter really growing in a ventricle in a place where it shouldn't be, and it was noticeable on the EEG, and then it turns out that she does respond to anticonvulsants, and she's certainly not cured, but psychiatrically she's a little bit more stable. In this case, in that same patient, what we're looking at are the deeper structures driving some of that theta excess and what it means, and as I'm going to get into, the origins of his problems really start in an area called the anterior cingulate cortex. And that's a really important area, as I'll get into, in terms of attention, in terms of learning, in terms of reward, and lots of measures that are associated with addiction. And then you can see the expansion of some of these abnormalities to areas that the insula in particular, areas that are related to emotion, and sort of the activity of his emotion, because in some sense attention involves executive functioning, which is about cognitive functioning, but it's also about emotional regulation and attention and executive functions related to that. And that's pretty much what this shows. The other thing that I always like to just show is how cool this is. Patients really like this. Whoops, got to get it to the right area though. Then you can do this 3D image, which is really cool. And amazing software to be able to do that. And you can really show people where there are abnormalities in their brain, sometimes in small areas and sometimes in larger positions. How are we doing on time? So, I had another case I was going to show, but I think I'm just going to move on and show you and talk about a few other things here. So, let me just go back. So, kind of putting this all together in a sense. So I'm focusing more on attentional areas, and we know how frequently people with addictions have attentional problems. They also have executive functioning problems, impulsivity, other types of symptoms. And all this kind of comes together in a way. So there's a few things we look at, and this is one of the great things about addiction medicine right now, is we have a lot of promising treatments and a lot of ways of dealing with our patients that make sense based on the theoretical models we have. So, we have the reward network, and that's kind of what everybody has talked about over the years, and this is basically dopaminergic transmission in areas basically from the nucleus accumbens and projecting into various parts of the cortex. And it's as if we could just block that dopamine transmission, then we could stop addiction, but it doesn't quite work that way. Although we can in some ways affect that reward pathway, and there's different attempts to do so. But another aspect of this, though, is that we now know that it's not just about dopamine, it's about other excitatory transmission and how that happens out from the nucleus accumbens and interacts with the prefrontal cortex and other areas of the higher cortex. And that's a very interesting line of treatment, so that we look at glutamate and glutamate modulation with mood stabilizers and other medications that can modulate glutamate. And they're turning out to be some of the most successful treatments we have for addiction, and even other areas in which I think executive functions are involved. So interestingly, I've had a lot of success with glutamate modulators in obsessive compulsive disorder. So there's a connection there as well. But we also have areas looking at the alert network, because really executive functioning is a combination of a number of different areas. So there's the alert that you get, that you have to be attentive and you're alerted and something happens. So we have norepinephrine transmission from the locus ceruleus, for instance. And we know that certain medications, clonidine or guanfacine, can block that transmission, and those can be useful in times of trauma, for instance. And we can also bolster some of the norepinephrine transmission with a few antidepressants, and at times probably increasing the alertness is useful in that sense. And we have orienting networks because one has to take that initial alert and kind of put it into some sort of context. And your brain is active in doing that, and that's where acetylcholinergic transmission comes in. Probably the most interesting, though, part is the executive functioning, which, again, affects cognitive functioning, emotional functioning. And I think this is one of the most exciting areas to me in terms of addiction treatment. And it also has a lot to do with attention deficit and the interaction. So what we do know is that areas that seem to be important are the dorsolateral prefrontal cortex, as I mentioned, the anterior cingulate, and the rest of the cingulate and posterior cingulate, the insula, the precuneus, are also very involved in aspects of executive functioning. And that's, as I was showing you on that 3D image, that's where you saw some deficits in this patient of mine that we were talking about. There was just an abnormality in that anterior cingulate, and some areas more, I think, dorsolateral that were impaired early on as addiction. So we also, again, see the interaction of functional MRI with the kind of quantitative EEGs that I'm doing in Loretta imaging. It's been shown in numerous studies that there's a hypoactivity both of the dorsolateral prefrontal cortex and in cocaine users, and then also hypoactivity in the anterior cingulate cortex. But what we can also, and some of this is probably predates their cocaine use, and that's the open question. But interestingly enough, if you take cocaine abusers and you look at them in short-term and long-term abstinence, you will see differences. So you will see increased activity in the dorsolateral prefrontal cortex areas, an area that probably has a lot to do with the impulsivity in many ways, and you'll see that decrease, and they have better inhibitory control kind of in the short term as a result. Looking at long-term abstinence, though, you can find increased activity in the cingulate, which means that it's later on that you're getting more activity in the cingulate, which is controlling some of the attention. And what it probably is controlling, to some extent, it's certainly a mixture, is about learning and reward cues. And so what parts of the cingulate are involved in are really monitoring, kind of monitoring yourself, monitoring the situation. And so some of those problems that we have kind of in the long term when we're trying to get our patients sober. An interesting thing is that if you stress the working memory of patients, they're going to start getting cravings. You're giving them cues and stressing their working memory, and you will see a bit of a decrease in those long-term abstinent cocaine users, that they'll start kind of losing some of that activity again. And it shows, how cues are so important in long-term abstinence. So what's interesting, again, is we have a number of medications now that are starting to actually attack that, primarily from glutamate modulation. And I think it's really amazing, and it gives us a way of kind of targeting aspects of addiction. It also means that we have patients, where we can be more specific about who needs stimulants and who has attention deficit. And clearly in some patients, treating that attention deficit properly improves their executive functioning to some extent, and also increases their odds of staying sober. And as I said, all these studies happened with functional MRI, but there's also repetition of these studies really in Loretta. Here's just, I don't even know if you could see it, but just an example of the difference between cocaine using and control subjects in terms of some of the activity here in the anterior cingulate areas. And, there's a lot more activity here and a lot less over here, basically. So I'm going to talk about a few things, but if I have time, but one of the areas that I've been really intrigued with over the last few years and gotten to do more of, and really getting excited about it, is EEG biofeedback or neurofeedback. And particularly, I'm really excited about something called Loretta neurofeedback, which is taking that Loretta technology. So basically, as you know, biofeedback is taking a physical parameter, more often it's pulse or blood pressure or something, and kind of training a patient to have some control over that physical parameter. And so a guy named Sturman back in the, I think, early 50s said, well, that's interesting, I wonder if we could change brainwaves. So he chemically lesioned a bunch of cats, and they would start having seizures, and he was able to use biofeedback and reduce the number of seizures that the cats would have. And basically what you're doing is giving, in that case, cats a crunchy treat or something. If their brainwaves are a certain way and they get that reward. And in humans, there's always the question of whether operant conditioning really can happen in humans, because this is really what it is. There's been a number of studies, and certainly the best studies have been for biofeedback, also called neurofeedback, in ADHD. And some of the, really, to me, the two most interesting studies are a large one in Germany. Half of the kids did a attention improving computer program. So it was actually possibly an active treatment, and it was compared against neurofeedback. And without getting into too many details, you'll see that 53% of the neurofeedback group responded as compared to 27% of the control group. And there was, a significant decrease in a German ADHD rating measure in the neurofeedback group compared to the essentially control group. Another interesting thing is this study by Levesque, which looked at kids diagnosed with ADHD, did fMRIs, found a certain consistency of findings there in the fMRI, and then after a course of neurofeedback, repeated the fMRI, which showed normalization, primarily in the hypoactivity of some of the medial structures like the anterior cingulate. I'll just skip over that. But now what's also really interesting is, purely on a research basis, people have started looking at fMRI neurofeedback. And that's trendy because the university just spent $5 million to have the machine. And so you can get a grant for that now. As it turns out, this real-time fMRI neurofeedback, there are an increasing number of studies really, I think, proving that the neurofeedback can be done. And so there's been some that have looked at modulating activity of the parts of the anterior cingulate, auditory cortex, sensory motor cortex, amygdala, insula. One very interesting study was whether you can improve the fine motor skills of a neurosurgeon actually by doing neurofeedback, and a group out of London was able to show that. And also, can you reinforce some of the attentional networks through fMRI neurofeedback? And so far, studies are really coming out positive for that. So the difference is, I think the advantage to me is that I can do the Loretta neurofeedback and have that kind of access to the deeper structures of the brain and do biofeedback, and there's every reason to believe that it's just as good or and as possible to do as the fMRI neurofeedback, but it's a lot cheaper and easier to do in your office. So, so we're doing a lot of that. And then, if I have little time, I'll go really quickly through the other way that I use this technology is really to guide psychiatric medication selection. And we call that a referenced EEG. And I've been working, this is my real research and work with a team over the years. And essentially we kind of brute forced this, and we took a lot of EEGs of patients who appeared to be normal, and actually that wasn't gathered by us, but then we took a lot of EEGs by people with psychiatric complaints, off of medications, off of drugs, gave them lots of medications over the years, and then recorded their clinical outcomes to the point where if I were to see a new patient, I take the data and I compare it to the database, although some of the patterns are very clear to me now, but I might say that, okay, you look like 400 other people in the database. They, 80% of those people responded to Prozac or something. So we have a way of using some of this data now to guide psychiatric medication, and that's called pharmaco-EEG. There's a variety of people involved in this and researching different aspects of it. What's interesting, though, is it's a way of saying, I don't care so much what their DSM diagnosis is. We know that's something formed in committee room. We know that most patients in real life seem to be a hodgepodge of different symptoms and could be diagnosed with like 5 or 10 different things. And we know that just because they feel depressed and they seem depressed doesn't mean an antidepressant works with them. They may not be very attentive, but it doesn't mean a stimulant works on them. And so why is that? And we say it has to do with the biology. So we're looking at actual biomarkers and less at the diagnosis. And here's an instance where we had 39 patients with a similar EEG feature, and there were some 17 different diagnoses. Many of them are similar diagnoses, but we run the gamut here of mood, attentional, anxiety diagnoses, and all these patients tended to respond to a similar medication. So our latest and best study was a study done with a team at Stanford and Harvard and places with 120 subjects, and basically what we were doing in this case was taking patients who would be diagnosed with treatment-resistant depression and had a certain level on their Hamilton Depression Scale and all of that kind of stuff that's normally done. And then we guided treatment using the best available algorithm for treatment-resistant depression, which is the STAR-D, which is a modified STAR-D protocol. And then we guided their medications based on the EEG. And what we found, needless to say, or I wouldn't be showing it to you probably, is that we were successful in, we're more successful with the EEG-guided treatment than following the algorithm. So you'll see a reduction in the QIDS SR, which is a quick inventory of depression scale. We found a significant improvement in the Q-less-Q, which is a quality of life scale. We're looking at percent improvement over the control group on a variety of measures. You'll see on the QIDS that we had about a 65 to 70% greater response rate to treatment, as well as about a 30% greater remission rate to EEG-guided treatment, and a number of other measures, primarily statistically significant. So what's interesting to me is basically all of these things are allowing me to target treatment in a way that I couldn't do before. I mean, there was a point in time where I was very frustrated with clinical care. It's like, okay, put everybody on an antidepressant, that should get them better. And in real life, it didn't. So what was wrong with that? Well, I didn't know what was really going on in the brain. I now have some ideas of what's going on in the brain. We have a lot of information about how specific behaviors and specific symptoms, more so to me than diagnoses, relate to abnormalities. I think that derive from a lack or improper development of the brain that we can analyze, and we can tailor our treatment to that with implications for a number of psychiatric disorders, and I think increasingly addiction. And we have a number of new medications that we can see how they're specifically attacking some of the abnormalities we're finding on this imaging. And I can also, basically have a way of getting past diagnosis and using what seems to be the more effective medication. And lastly, also, more and more I see neurofeedback as a way of targeting specific areas of the brain and getting some response. And I didn't show other studies, but for instance, there's a good study out of UCLA showing how after 6 months compared to the control group, there was a higher rate of neurofeedback subjects who didn't relapse and had improvements on their psychological scales. So we can see bits and pieces of this neurofeedback being demonstrated and allowing us to target specific areas of the brain. So, I feel like we're actually now moving into the 21st century. And I've been given that sign, so
Maybe just
I will.
questions.
Yeah, questions. Two questions.
Susan?
I'm curious when you're talking about the development of the adolescent brain and the different wave action that happens, are the changes that are going on in the brain just developmental and what happens anyway, or are they based on external events? So in other words, is maturity about brain development or learning from falling on our faces?
Well, I think it's probably a combination. I think most of it is pre-programmed. The culling of the neuronal synapses, for instance. I think there's aspects of somebody's development that may impair that process, though. So I think it's sort of something actively preventing things from happening. But some of it is also genetic. We know from a type of dopamine receptor, the DRD4, you can find abnormalities in that, and that probably reflects some of those abnormalities in the anterior cingulate, for instance. So we know that some people are genetically predisposed for some of this, and we know that personalities are 50% genetically based, basically. But it's also true that the brain is plastic, and so some studies can show that in the right environments, one can improve the executive functioning of young children, which probably is reflected in some of the findings you might find later on in life on a biological basis. Alethea?
So the first EEG that you're going to do before you determine what meds might work for them, they have to be completely off substances, correct?
I do it different ways. I mean, sometimes I'll do a quantitative EEG and I'll try to, I know some abnormalities are more likely to come from medications than others. So, I'll take that into account, and I'll take where the patient's at. I mean, I certainly not looking to destabilize people. Some patients, I do, they're in the space where they want an ideal test, and we try to do as ideal a test as we can. Okay, I guess.
Thank you very much.
Well, thank you very much.